Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, go down to the description and you can download the PDF of this file so that you can follow along yourself, save it for later. Don't forget to like and subscribe while you're doing that. And yeah, so let's jump into this ECG. So first thing I like to do is look at the forest, and the trees of the forest are my QRSs. And what you'll notice, if I maybe start off at this lead 2 rhythm strip here, I've got a regular narrow complex rhythm. My QRS appears to be pretty regular and narrow, and if you look through the whole strip, it seems to kind of stay that way. I like to determine the rate by finding maybe a QRS that lands on a solid line, and I'll count 300, 150, 100, and this QRS lands a little bit in the middle of 150 and 100, so I would say maybe 130 beats per minute. I'm just gonna kind of guesstimate that. So we would go ahead and call this a tachycardia. Alrighty, so we've got a narrow complex tachycardia that's regular. Okay, so we're starting to kind of work through what's going on here. And I do see that there are what appears to be P waves just when I look through in front of my QRS complexes. So let's kind of deep dive and get into the details. First thing I like to do is evaluate what is the atria doing to drive this rhythm. We already said we have some P waves before our QRSs. My P waves appear to be, if I look, here's a P wave in lead 2. If I look up, straight up, that should be my P wave in lead 1. It seems to be isoelectric in lead 1, which means it's probably heading perpendicular to lead 1, and it's upright in AVF. So my P wave axis is probably going more down towards AVF, and I would say that's somewhat consistent with a sinus P wave, especially 130 beats per minute is something that the sinus node is typically capable of doing. So we've got a sinus rhythm here. Next thing I'm going to do is evaluate the next portion of my electrical conduction system, which is my PR interval representing my AV node function. And so the PR interval, I like to find a strip that's got a nice sharp P wave. Usually that lead for me is V1. So I find this P wave before my QRS, and I mark right in front of it when it starts, and I mark the beginning of my QRS, and I notice that my PR interval is less than 200 milliseconds, which is the upper limit of normal, and so I would say that we have a normal PR interval, so that's good. My PR interval also stays the same throughout the rhythm, right? So you want to scan through and make sure, does the PR interval stay the same? Does every P conduct to a QRS? Because there can be blocks that are variable. So next thing we're going to do is let's evaluate the QRS complex. My QRS complex is generated when the AV node passes its signal down to the ventricles, and so we can start by measuring the width of my QRS. And my QRS here, the QRS width is less than 120 milliseconds, which is good. That's narrow. That makes me think that there are no conduction blocks within the ventricles. My axis, it appears that my QRS here, if I kind of look up, that's where my QRS is. QRS seems to probably be also isoelectric with lead 1, but it is, as you can tell, upright in my inferior leads, and so that tells me that my QRS axis is probably predominantly down, which is within a normal range. So my axis is normal. I'm happy with that. We can look for R wave progression, and you can see we have some pretty poor R wave progression in the precordium, right? Usually we have a little R here, which we don't really have, and we don't see a growing R wave throughout the precordium. So we'll investigate maybe why that's going on, and some of you guys might already even know. So, but we're going to go through our methodical approach. Next thing I like to do is evaluate the QT interval. Sometimes what I'll do is I'll just find QRS complexes, maybe this one and this one, measure midway between the two of those. So the midway point is maybe here, and I want to look down and see, does my T wave end by that point? This is my eyeball test of QT interval, and I would say in this setting my QT interval seems to be okay. It is not kind of outlandishly long. And next thing we're going to do, now that we've gone through that, is we're going to look for pathological Q waves and ST changes. This is our ischemic workup, and what you have noticed is predominantly my anterior leads have these big ST elevations. And so my anterior leads are V3, V4, and if I zoom in, you can see my baseline here, my ISO, or kind of the baseline of the ECG is there, and you can look at that ST is very elevated. I would say 4 to 5 millimeters elevated in V3. Also here in V4 in the same way, very elevated, and even some minor elevations, kind of residual elevation in my lateral leads, less so. So we can say that the ST segment elevation, my ST elevation, is predominantly in the anterior leads within the precordium. You can see we also have a little bit of elevation here in the inferior leads, maybe not so much here in lead 3, a little bit more in AVF, and so it seems like if you look at in the inferior portion, leads 2 and AVF, they're more kind of capturing left ventricle. So maybe getting a little bit of residual of what we see is predominantly anterior ST segment elevation. And if you look, remember our diagram here of the transverse cut of the view of the heart, where we've got the left side of the heart here, you can see pretty quickly that these anterior chest leads, V3 and V4, which we said have the most segment elevation, they're really capturing the left ventricle here. So all of the segments that are elevated in these anterior chest leads, since they are the most elevated, this is very much likely an anterior ST segment elevation. And so what we can kind of think through is, well, what vascular supplies this area? What pieces of vasculature supplies this area? And we know that the anterior portion of the ventricular system is supplied mostly by the left anterior descending artery, which descends just kind of in the interventricular region between the right and left ventricles. So that supplies kind of the anterior septal region. All right, but we're not done, right? Let's take a look at maybe what's going on. They're having a ST segment elevation myocardial infarction, but we also see these pathological Q waves, right? These are some deep Q waves throughout the precordium, especially here in these anterior leads. These are very prominent Qs, right? A Q wave is the first deflection. And so this is telling me that there is a significant amount of myocardium that is probably completed in infarction. So maybe we're a little bit later in a presentation for this STEMI. And so this person's got deep pathological Q waves in the anterior leads and a little bit here in the lateral leads that correlates to some of that lateral elevation. And so this person does pretty extensive damage so far. And so we can go ahead and just note that pathological Qs in the anterior leads as well. And so let's put this all together. And so what we got is we have a sinus tachycardia at a rate of roughly 130 beats per minute. We've got ST segment elevation predominantly in our anterior leads with some pathological Q waves, which tells us that maybe this infarction and occlusion of the left anterior descending artery has been going on for enough time, maybe a handful of hours, to damage some of this myocardium. So important takeaways here is when you're looking for ST segment elevation, right, we've got what we said, ST elevation. Sometimes you can look for something called reciprocal ST depression. And if you look here, we didn't really find a whole lot of depression other than maybe in this AVR, right? AVR maybe has a little bit of depression. See the ST segment, it's a little bit lower. And so sometimes ST segment depression can tell you, yeah, is this ST segment elevation pathological, right? It was hard to deny that this was the case. And also you got to think reciprocal depression is because of leads that are on the opposite side of the leads that you're looking at. And so if you look at the anatomy of our anterior leads that are right here, V3, V4, there really aren't reciprocal leads on the other side over here that are going to really capture depression or the opposite changes. So I hope this helps, and if you have any questions, throw them in the comments, and if you enjoy the channel, feel free to subscribe. See you tomorrow.